Anonym. Good morning, everyone. It's good to be here with all of you again at the Pacific Basin Medical Association in Chuuk State, and appreciate the invitation, and I certainly appreciate the partnership. Today, actually, I'll be talking about partnerships in health and the regionalization, and really how regionalization is really an important asset, and it's something I've been thinking about for a while, and to kind of speak to that and what has come out of these regional partnerships that we've developed, had, and continue to utilize, including the Medical Association in the Pacific Basin. Uh, Today, again, the regionalization as an asset, I'll be talking about, leveraging this asset, which allows us to build partnerships, build healthcare capacity, build regional health programs, and certainly implement many health interventions together. And together, of course, we're stronger. So when I talk about regional partnerships, um, these partnerships are interconnected and we're interdependent on each other. And the partnerships I'm talking about are, of course, the Pacific Basin Medical Association, PBMA. It's the Pacific Islanders Health Officer Association, POA. It's PIPCA. It's a CCPI. It's PCDC, and there's, of course, others. But these are the major ones that are probably active right now. And again, I recognize there are others that are not mentioned. The PBMA, provides interdependent clinical support amongst all the USAPI, and that all of you know that who are here. It really helps us with project readiness. So when other partnerships or folks come in, the PBMA and PBMA members often are the brokers of that program within their jurisdiction or within their region. It helps them with the human resource development. It creates helps us with creating a single medical voice in the Pacific region. It helps us share best practices between all our jurisdictions, and certainly some of the best practices and the friendships we develop. And it supports some regional training of Indigenous Pacific Islander peoples, and the connections within, and even many of you are, I noticed, and are part of PRIDOC, the Pacific Regional Indigenous Doctors Association. And so again, that's PBMA. PHOA, of course, is about capacity building grants and programs within the USAPI, human resource training and labs, VACITI. It's about program grants such as lab and TB, and working with Dr. Brostrom. It's a lot about health leadership coordination of the, secretaries of health, the ministers of health, the hospital administrators. It's a platform to exchange ideas and programs vertically. So not only do the ministers in health talk to each other, but it allows a dialogue so that the clinicians, the different programs, can enter into that discussion in a meaningful way. PHOA has launched the NCD Emergency Declaration. And of course, a lot of the issues that many of you have been talking about, data management, the MANA dashboard with Dr. Duran and Haley Cash, and linking to the CDC, which is a big one for programmatic support with Dr. Brostrom, Dr. Hancock, Dr. Taiho Chen. And then there's PIPCA. PIPCA, is a CHC dialogue and development. And many of you have the CHCs in your jurisdictions, but how you talk to each other, how you sustain the organizations, how the PBA members, many of you are parts of this, the PIPCA organization, and flow in and out with them to work in your jurisdictions. And then there's the Cancer Council of the Pacific Islands. I'll be talking about that. It's regional registry, the REACH program, cervical cancer programs, and so forth. And it's a PCDC, and it's largely it's a diabetes collaborative. But when I talk about the regional collaboratives, the interconnectedness, it makes the Pacific a very strong area to have these individual collaboratives that are interconnected, work with each other, and help to take us to the next stage of development of health in the region. So, our genealogy in the Pacific's very, very important. And I'll be speaking to the CCPI because that's what I know best. and its genealogy. But its genealogy began with PHOA and PBMA. I want to emphasize that the CCPI and the Pacific Regional Cancer Efforts started there. It actually started in when many of the jurisdictions, I used to come to many of the PBMA and PHOA meetings, even after I left the Marshall Islands in 1991. It, and they kept talking about, and I saw it even when I was in the Marshalls, the rising amounts of cancer in their region. And we talked about that at several of the PBMA meetings. And so finally, at the PBMA meeting, it was recognized, well, let's do something about it. We all recognize as, our individual jurisdictions, it's a huge problem. It wasn't quantified very well. And also, what would be the next steps? And the next step was to understand it. We needed resources. And so the mission that I was sent on through the PBMA after speaking to a group it was YAP in 1997, was to then talk to PHOA and Guam. And they too said, this is a big problem. Let's go get some resources. And so we launched on that journey. And then it was a matter of looking for resources to kind of try to figure out how to do that, and then worked with the Intercultural Cancer Council and the President's Cancer Panel in the U.S., identified some resources there. And finally, in 2001, the National Cancer Institute put some funding this way, and we started developing the regionalization concept of the Cancer Council of the Pacific Islands. But the emphasis here, it began with the regional bodies of the PBMA, many of you, and with PHOA. And so in 2005, after we developed the, initial beginnings of the Cancer Council of the Pacific Islands, we worked to get a cancer registry going. We built partnerships to get this registry through the CDC assessment. And then in 2007, after we got the registry going, we looked at the CDC REACH program to leverage more funding into the region. And the REACH program is a racial and ethnic approaches to community health, when we became a Center for Excellence. In 2018, we acquired a Bristol Myers Squibb Foundation telehealth grant. And in 2020, we're now doing a primary HPV screening grant. But this story is our genealogy, but it's a genealogy that really started, and again, the emphasis is from regional bodies, regional thinking, PBMA, PHOA. Then it evolved into the CCPI and many of these efforts. So this is the initial shot of the, Cancer Council Pacific Islands with, you saw its history of, hustling for funds and getting some from the NCI and working with the President's Cancer Panel and so forth. But you can see many of the members are in this picture. I see Dr. Hedson and, Dr. Nadan and Dr. Kamal and, Dr. Liv and Kino and, many folks that have been, part of us, and some of them are gone. Dr. Vita Skilling and, Dr. Soledad is here too as well. But again, you can see how the regional body, the PBMA, not only strongly influenced the Cancer Council of Pacific Islands and work, but was part of it. And so, again, I just wanted to mention that. And in this picture, of course, salute those who have passed. And the regionalization, of course, it's a collaborative. It's about using multi-sector coalitions for the CCPI. And the Central Regional Group is a representation from all of the 10 jurisdictions, the 4 states in FSM, as well as the FSM National, and all of the territories, as well as the different republics of Palau, of the Marshall Islands, and again the Federal States of Micronesia. But it uses an economy of scale, as does the PBMA and the PHOA. It looks at the common assets, the common challenges. And again, it allows us to speak with one voice in the global arena. And so the CCPI, I just wanted to show you that the power of this and emphasis started with the PBMA and POA is that it was able to then build cancer coalitions in each of the jurisdictions. It then was able to land, comprehensive cancer planning grants for each of the jurisdictions. And then those grants are used now to fund the CCPI here. The CCPI then had hustled and together as a cancer council that you saw, developed the cancer registry. And now the cancer registry is each of the Pacific jurisdictions. The racial and ethnic approaches, depending on the funding level, was in each of the jurisdictions. Cancer telehealth is throughout the Pacific. And then now the Pacific Cervical Cancer Program intervention, which I'll be speaking about further, is this. And then we've also been able to harness the energy from the University of Hawaii Medical School, the Cancer Center, international partners, SBC, WHO. So again, regionalization and the Pacific partnerships have allowed this to happen, but it comes with the collaborative effort of all of you, all of us, and we now come together to kind of use these efforts to work further in the dimensions that we have to work. So the CCPI, of course, as you know, is two representatives from each jurisdiction, designated by the senior ranking health official in the clinical space and in the public health space. And it works on human resource development for cancer, surveillance in cancer, training in cancer and cancer registries, prevention programs, screening programs in cancer, and of course the treatment and palliative care efforts for cancer in the region. So you saw that we began here. You saw this slide, but I want you to notice this. That was in 2003, 2004. This was in 2009. You can see many of the faces here of many of you who are a part of the Cancer Council of the Pacific Islands and PBMA. And then this is from 2019. So the body gets bigger, and you can see there's directors here. There's CHC executive directors and so forth, and people that are cancer coordinators, cancer registry folks, reach folks, planning folks. There's folks from the CDC in this, but it's all that partnership that allowed this larger partnership, pulling on multiple funds to make the regional work a lot stronger. This was 2019, and then this is in 2024 at the Cancer Center in Hawaii. And again, you can see many of the faces from throughout the region. I see Dr. Tolman there, and Dr. J there, and so on and on. But you can see it is a regional effort. Dr. Taitano, and this is the dean of the medical school, and this is the head of the National Cancer Coalition in the U.S. And of course, we see Martina and other folks here. But again, just to point out that that effort continues. It began, again, with the PBMA, with PHOA, and this is what leveraging is about. The registry, just briefly, it was leveraged out of the CCPI. Funds are from the CDC, and we had to develop policies for reporting in every jurisdiction. And the members from the PBMA helped us work on that. But we had to work with the data, cancer data, and the vital statistics data in every area, so that we improved mortality reporting, the documentations and medical records. So you can see how it leverages and works into exactly what you have to work on a daily basis, as physicians and clinicians. And then, of course, the racial and ethnic approaches that works with policy systems and environmental changes in every jurisdiction. There was since 2007, and it really aims at preventing chronic diseases with a focus also on cancer. And they're participatory. We work with every jurisdiction, and this has allowed us to hire folks in every jurisdiction who are part of the REACH program. So one of the benefits of the regionalization with the CCPI and then the registry, there's registrars in every jurisdiction. There's REACH members that are hired every jurisdiction. So these are the folks in your areas that are hired through these grants to work on the different approaches that we are talking about. The telehealth program, this was something that was funded through the Bristol Myers Squibb Foundation, and offers CME credits to many of you. It's total of was started in 2019 with 58 sessions, and now, though it was started by Bristol Myers Squibb funding, it's one where we now use just the efforts from other grants up here, and there's been 500 total attendees. There's been many oncologists who have spoken to the region. There's primary care initiatives. There's people who work on research in the area. But these sessions, not only do they provide CMEs, but there's some of the cutting edge discussions on the science of cancer care, cancer treatment, cancer screening in the region. And so it's been something that's been of high uptake in the region. But this has also been generated from grants that have come through the efforts of what all of you have started. And this one I wanted to just chat about in a little bit more detail. It's a Pacific Against Cervical Cancer project, and it's to decrease cervical cancer morbidity and mortality in the region. And it's something that has been also generated out of the efforts of the CCPI members, again, which originally, and many of those members are part of the PBMA. So in November 2017, 2020, the WHO launched a global stride to accelerate the elimination of cervical cancer. And why I start with this slide is to say that actually the CCPI, and many of you, we started this initiative to eliminate cervical cancer in the region way before 2020. In fact, it was something we recognized way before, and we started launching it. And in fact, the strategy to eliminate cervical cancer in the region has three main pillars. It's that 90% of girls are fully vaccinated by age 15. The second pillar is 70% of women who are screened receive a high performance test twice in their life at least, and that 90% of those identified with precancer through this high performance test, receive treatment. And so again, this is how you reach a threshold of 4 cases per 100,000 in your own jurisdictions. And what we had to do, we actually began our own strategy in the U.S. affiliated Pacific through the CCPI. It actually began in 2010 when we recognized it was a big problem in the Pacific through the registry data. And we also noticed that every country was noticing there was a lot of very advanced cervical cancer in the region, and that pap smears weren't working very well in their region. So the background scenario is that, just as by way of some background on this, there's 3 general ways of screening for cervical cancer, as you know. Pap smears are looking at the cells on the cervix to see when they're changing. And you can see, it goes from, the CIN 1, 2, 3, and then 4 into, cervical cancer. VIA testing is a technology where you don't look at cells, but you look at the staining of the cervix, and the cervix will stain a certain way using vinegar or Lugol solution, where Lugol solution is an iodine solution. and the cervix stains a particular way. And with trained eyes, you can tell which areas are changing, and that's where you focus your biopsies. Or if it doesn't stain in a particular way, you know that it's for that period of time, it's perhaps clear. And then, of course, the one that now with the science of DNA HPV testing, the cause of cervical cancer is high risk DNA human papillomavirus. And so that it is the most effective, the lowest cost, and the highest sensitivity and specificity of any of these tests. And it has better utility in women because you can do self-testing, and so you bridge many of the cultural issues. So the science has been to move to do effective screening, because in many of the areas, as you know, pap smears cost too much because they have to be sent away to labs. You have to wait for the results to come back. By that time, you couldn't find the women, and it costs a lot of money. HPV DNA testing, on the other hand, you can do the DNA test on site. You can do it, within 4 hours, and you can get the results. It is quick, and if you use self-testing, you can do screen and treat, the same day. So again, it's the movement of science and efficiency and cost. And so this is kind of the diagram in high resource and middle resource settings. They use cytology-based pap smears. U.S. use pap smears, and it's one where, and it was a technology of the day. They use a lot of conizations and LEAP. The physicians were used to do the sampling largely, whereas in lower resource settings, it was using self-sampling, using the molecular DNA testing. There was some visual VIA, but everything moved in this direction. And so, and the entire science is moving in this direction, even in high resource settings. In fact, the only place that's a high resource setting that continues to use pap smears as a primary coverage is the United States, its territories, and Britain, Canada, Australia, France. All the rest of the countries are now all moved towards HPV DNA testing as a primary mode. And again, the science is there. It's the best, most cost effective. And one of the things that we did with said registry data, just to show you that you can see that crude and invasive cervical cancer sites is women in all of these areas. In the Marshall Islands, it was 66 per 100,000, whereas the U.S. it was 7.8. But the thing I just wanted you also to notice is, remember the elimination strategy is 4 per 100,000. The U.S. isn't there either. Using its pap smears is better than a lot of these other areas, but it's not at 4. YAP is about 20. Palau's at 9.9, 10. Guam is here. So again, it's not even here. And certainly many of these areas are not only not higher than the United States, it's, unfortunately, significantly higher in some of our U.S. affiliated Pacific Islands. And this part that shows the percent that die with cervical cancer within 5 years is very high. So Marshall at 45%, Guam 29%, YAP 69%, and so forth. And even Republic of Palau 53%. What does this mean? It's caught at very late stages. It is caught at late stages. And this doesn't have to be. Cervical cancer is totally preventable. No woman should die from cervical cancer, period. And so this is a tragedy. And to realize that it is an issue. But that's why we're working on it and have been working on it for a very long time. And you can see women aged who are not screened in these areas. And this is actually from 2018, 2016, 2021 data through BR FSS, and so forth. But in 2018 in the United States, 19.8 women were never screened for cervical cancer. But in the rest of the Pacific, you can see it's high that who have not been screened. And then it translates into late cervical cancer death, and no woman should have cervical cancer, and certainly no woman should die from cervical cancer. So we then put together the PACE project, and when I talk about the regionalization and why partnerships are important, when we began this project, it was hard to find funding, and finally, the funding for this project, we tried going to the NIH, and the NIH wanted to do it, but they said it has to be a research project. And we said it's going to be hard to stage up a true comparative research project in the Pacific. So the CDC came to the rescue, and they said, we will fund this. They gave the funding to PIHOA. PIHOA then, because it does, grants to develop a health resource capacity. PIHOA said, University of Hawaii, can you put this program together? And we put it together, and we put together a medical protocols and laboratory team. And the initial folks on this were NCI heads, Phil Castle, some of you might know him, but he's now the head of the NIH Preventive Services team. But it's changed for many reasons. One is he went to the NIH, and that so far he couldn't work on this. We have a community engagement team. We have a CDC epidemiologist on this, and we have a modeling and projections team from New South Wales. The beginning of the program, we wanted one high resource center, so we began the program in Guam, and the other one was in Yap. And where we just wanted to show you, we had several elements in this. As you can see, we had a community engagement part. And so with this is the key elements in Guam. And so in Guam, you can see this is the team that PACE engaged. And there is a guy you all know, Dr. James, and he kind of was a broker and headed up a lot of this. And this is in the training of community health workers in Guam, which was a little bit harder uptake. And I'll explain that why that is. But this is that effort. And using the community health engagement, there was a lot of work and multiple, different products were developed for education of the community, including these different brochures, one specific for Guam, one specific for Yap. It was translated into several languages in Yap, from Yapese to Salawalese. In Guam, because they have a lot of migrant populations there, Kashuayan, Pohnpei, Tagalog, and Chuukese, and these were the brochures. And one of the things that we found out was very different. The systems in Guam and Yap, as you know, are different. So setting up the HPV testing and the whole sequence was quite different. Yap, of course, has one health system. And the Yap State Hospital, the community health centers, and the outer island dispensaries are strongly linked. But Guam, though it's one island, it has multiple different systems. It has private clinics. It has public clinics. It has federally funded clinics. It has clinics that are associated with various churches. It has 501c3s, and then it has the community health centers, which are, of course, funded through HRSA. And then the, hospital is a separate entity. And so working with them was very different. And also they have to respond to the FDA, US regulatory agencies. And YAP has to, doesn't need to respond to that, but has to respond to, of course, what's happening with the greatest science in the rest of the world, and which is what allows them to work much quicker on the platforms it has worked on, the same ones, again, that UK and Australia and Canada and a lot of the other countries in the world have been working on for a while. And so this is skills building in YAP, and you can see, you know, uh, uh, our champion from YAP here, Dr. James, and this is them doing these different courses, and this is Dr. Waxman training some folks in Guam. And just so you know, you can see the difference in yield. And so both of these areas started at the same time. The number of women tested with high-risk DNA testing has been almost 1,500 now. And it's because, again, to push it out and to make it work in a unified system worked a lot quicker. In Guam, it's only been 55. But now that it's moving, because we have to work with insurance companies, we have to work with a lab in Hawaii, and on and on. And even, I just want to let you know that YAP has actually screened women in Sarawak. And Sarawak is 700 miles away from the main island of YAP. And so again, this is a very effective test that can be used very effectively in very distant areas. And so, it's just a tremendous way to work, but it's something we have been working on through PACE. And we have then shown that in FSM, this is FSM data, if you work at the status quo with what you're doing now, between 2023 and 2072, there will be 600 to 943 cumulative cases and deaths over the next 50 in this period of time. And so this is the deaths right here, 510 to 690, and these are the cases. So FSM goes at whatever they're doing right now. This is what happens. If you use HPV scale up, you can see that this graph shows how many deaths you can avert by doing that with the same vaccination rates and treatment access as you can just by using HPV testing alone. You can avert 63% to 48% of the cases, and the deaths you can decrease by this amount. And of course, then if you increase your not only the screening but the vaccination rates, you can eliminate 80% of the expected deaths. And this has been done through the modeling team, which is a very sophisticated, and it's something that is new and possible because we know about the science of HPV DNA. So again, it's very, very powerful to not only understand how the modeling works, but why you want to get high coverage of vaccination, why you want to use HPV DNA testing. And YAP, will hit its 90, 70, 90 targets by 2030, and probably hit its elimination 4 per 100,000 by 2050. But the whole thing is to move the three pillars: screening, treatment, vaccination. And for those who are wondering, well, what if we just continue doing a better job with pap smears? So this is actually modeling Guam, and if you use pap smears, the current practice in cytology, and there's 47% screened, it was 47% screened, and this is a 4 per 100,000 line. You'll never get there, even by 2099. If you switch to, if this dotted line is if you switch to 5, the HPV testing and maintain the rate of screening, only 47%. You can see what HPV screening does. It allows you to at least hit here. It'll be by 2089, but it decreases the rate significantly. But if you jump up to 70% screened of the women, which HPV testing allows you to do, because you can reach the harder to reach populations, the more distant, the more rural, and the women who don't want to come in because of the pap smears are very uh, intrusive, you will actually hit it much earlier. And this is exactly from Guam data. If you just do this. And so again, very powerful knowledge of what the limitations are of cytology, pap smear, why you want to move to HPV screening. And so we just want to show you that in Guam, we also model what happens if you switch over to HPV DNA testing, save a lot of lives, and a lot of cervical cancer are avoided. So the conclusion that I want to just come to is USAPI health partnership and regionalization is critical. It helps us leverage each other. It helps build capacity, build innovation. This is not CCPI's work alone or pace. This began with the PBMA. This began with regional thinking. This began with PHOA. And it's a regional dialogue for knowledge exchange and translation of knowledge. We are interdependent on each other. We work at multiple levels, so leadership levels, technology levels. And so PBMA, PHOA, and the CCPI are critical, certainly. The PIPCA is critical. We operate on an interdependent, not a dependent level. One depends on the other to better healthcare delivery. Now, the challenges and why I'm talking about this is because we have to manage change. A lot of times, new leadership and new members don't know the history and the value of the partnership. And there's new health priorities, the geopolitical changes in the region, and funding changes. So a lot of times, people are not sometimes allowed to go to PBA meetings. Sometimes new leaders don't want to support the CCPI. Sometimes they don't want to support the registry program. Sometimes they don't understand the value of it. They don't know where it began. They don't want to support initiatives in PHOA, or they want to quit PHOA. They want to quit CCPI. But the point is, it has great value. Many folks don't understand that value. And we're 30 years into this, 35, 40 years into this. And so with that kind of time change, people change, people pass that were critical. We're getting older, the folks that were here at the beginning. So I think it's one of really having a dialogue and documenting where the PBMA began, PHOA, CCPI, PIPCA, why this regionalization is important, why understanding how it all works together is important, and what our role is as individual members to make sure that we keep all the work we do important, because certainly it doesn't only foster friendships like mine with many of you. I wouldn't have known many of you without being part of the PBMA or the CCPI or working with PHOA. So anyway, I just want to say friendships, relationships, and the work, we're interdependent. And that's what I wanted to share today, that PBMA, Chuuk, PBMA, thank you very much. And keep going, keep generating new stuff, and keep the health in the Pacific get better and bigger.